here today, and thank you all for coming. It is so great to finally get to see everyone. It's been a long time coming. For those of you who I haven't gotten to meet yet, I'm April Torres. Last year, I started EDS Louisiana when I realized how necessary it was to do so in order for others like me to be believed, to be validated, and to feel supported. I had lived 45 years without ever hearing the name dysautonomia or Ehlers-Danlos syndrome. As a registered nurse, I realized how wrong it was to know that most nurses have no idea about these illnesses. I realized that it was necessary to form a legal group in order to be heard and taken seriously, not only by doctors, but also by my own family. Without this, I realized they would continue to disregard my illnesses and refuse to accept that they were indeed very real. And that was traumatic for me. All my life, I had struggled with feeling lightheaded, easily fatigued. I would feel really sick after I'd eat, and so much more. I was called the dramatic one, the Miss Scarlett O'Hara, the Miss, there she goes again. What is it this time? Others would insinuate I was faking when I would say I didn't feel well. Not being believed really did a number on me. I struggled with depression and anxiety for many years, and it was life-changing for me when I realized that all of my issues does indeed have a name. And shortly I realized that if I, as a nurse, hadn't heard of these, I realized that there were so many more. There had to be so many more of my Louisiana brothers and sisters that might never, ever know or learn that what they struggle with is truly an illness. And it caused a stirring in me, and it wouldn't let me sit still. I had been so exhausted for looking for a diagnosis all my life. When I finally found it, I thought, oh, good, I can rest now. But I couldn't sit still. I just couldn't stop thinking of all of the other ones that might get to the ends of their rope, and it wasn't okay. So I'm very shy. I've always been very shy, but I felt like the urgency to do this. So this is me rising up out of my comfort zone. And I need all of y'all's help. There are so many better equipped speakers. So anyway, I wanted to say, our mission with EDS Louisiana, our mission and purpose is to create and ensure a better Louisiana where EDS and dysautonomia are seen, heard, and understood. We want to make it much, much easier for the rest of us who's out there and still doesn't know that their illness has a name. And I just wanted to make one quick announcement that once a month we gather for an hour and a half for our support group. We have an active Baton Rouge group, an active Lafayette, and an active Covington group right now. And we are in the process of trying to get with others to set up more meetings around the state. So, and after this is over, we will be meeting at 3 o'clock. It just happened to be this was the day that we had it set up for our online Zoom meeting. So without further ado, let me hand this over to Carmen Gonzalez. We can't hear you though. You're gonna have to unmute yourself.
You there?
Yes, we can hear you.
Okay, thank you so very much. I don't know that I had the opportunity to meet each and every one of you guys, but there's a lot of faces that I see here are very familiar, and a lot of names that I've spoke to or text messaged on a regular basis. My name is Carmen Gonzalez, and I am the founder of Dysautonomia Louisiana. I started Dysautonomia Louisiana in 2015 by requesting a proclamation from the state governor to declare October as Dysautonomia Awareness Month, because I knew there had to be more people with dysautonomia, and I had only met one other person with dysautonomia in my travels. So now we're 400 people strong in our group, and I've spoke to many of hospitals and counseled people, as well as we've done educational seminars. We do a lot of proclamations in the month of October. I try real hard to focus on being our a awareness group. We do some support group measures. Dysautonomia International Louisiana has a support group. We're just a support, an awareness page. We don't get a lot of questions and answers in our group, but we do a lot of educational events. So having that said and done, we work 11 months out of the year to make October the month that we focus on doing awareness events. Usually we request all 64 parishes to do something during the month of October. We have touched and done events in 36 of the 64 parishes. So we are turning this state turquoise. And that's the goal for Dysautonomia Louisiana. The goal is for us to find all the other Carmens and all the other Aprils and all the other Sammy Joes and Colleens and Ashleys and all the people that they have out there that haven't been touched. They don't have to travel the journey of dysautonomia and EDS by themselves. So together we're able to create awareness. And I have to say, I could not do this by myself. It takes a group of people to get together to rally the state of Louisiana to create awareness. So we would be able to do this without the support of Dr. Umesh Patel, who is going to be the one who does our questions and answers. We've probably got about 12 or 14 pre-submitted questions we're going to do. I did want to make everyone aware that this video is recorded and it will be played at a later date. And I'm hoping everybody is within agreement of that. So just so you know, throughout the question and answers, when the pre-submitted questions, Dr. Patel is going to answer them, April's going to read them, and then we're going to save the last 15 minutes of the meeting for live questions and answers. So I will give you guys a buzz at about 12:45 just to say, hey guys, we got 10 minutes to wrap it up, and then we're going to go live. So April, if you want to go ahead and start with your first question that was submitted, and then turn it over to Dr. Patel to be able to give us those answers that we've all been waiting for.
Okay, well, first off, thank you, Dr. Patel. You are a lifesaver to so many of us. Like, words can't even begin to tell you how unbelievable it feels to be validated and to be told we're not crazy. So thank you so much. So the first question that was submitted is, it says, I don't really have a doctor that follows me or helps me with my dysautonomia or POTS. I'm told that I have it, but I would like to know if it's normal to have breathing issues. And when I say that, I mean, I deal with feeling like I can't take a deep breath in, and my stomach also looks bloated, but this happens a bit, and I have to lay flat and prop my feet and just wait for it to stop happening. So I was curious if this is normal with dysautonomia.
Okay, well, thank you very much, April and Carmen, for the introduction. Just so the other folks who may not know me, the reason that this is a combined meeting for both the groups is it is actually dysautonomia and EDS is all part of one big ball of wax. So we'll go over that a little later. But just also, so those folks who don't know who I am, I'm a cardiologist who's a preventative cardiologist, and I've developed an interest in helping patients with autonomic dysfunction. And more recently, after coming across April, I've started trying to help the patients who have EDS, because it's all kind of linked together. And I see we have a lot of questions, and I may have to go fast because I want to make sure everybody gets answered. So please forgive me if I don't go into too much detail. I tend to do too much usually, so we'll see how it goes. So to answer that first question, the abdominal bloating, actually, that's a very common symptom in autonomic dysfunction. And it's really a response of the autonomic system to triggers. Could be anything, could be ingestion of certain foods, allergens, what have you. And then next thing you know, the autonomic system sends a wrong signal to the bowel and the gut and says, okay, relax. And next, the inner organs, the bowel, and expands. And so that's where the bloating comes from. And in some patients, they actually have uncomfortable cramping because there's a confusion in the autonomics as to, are we opening up or are we shutting down? All this is actually related also to other disorders like gastroparesis, slow transit constipation, irritable bowel syndrome. There's a whole gamut of gastro disorders. Going back to that original question, I'm not quite sure if I can answer honestly why that particular person would feel bloated when they lay down, but yeah, it sounds to me like there may be some kind of an autonomic stimulus that is sending this off, and off it goes. I also noticed one of the comments on that was that that individual felt better when they lay down and put their feet up, which kind of, again, points towards not enough blood was getting to the autonomic centers up in the brain and in the spinal cord. So laying down and raising the legs actually sends more blood down there, and lo and behold, things calm down, the system works normally, and the bloating goes down. I'll take the next question, April.
Okay. It says, I try to work out and push myself as I want to be healthy and back in shape. Well, I did my Ring Fit on the Nintendo Switch and got my heart rate up to about 145. I finished my workout and was kind of dealing with the shortness of breath, so I paid down to try to get my heart rate down because it was taking a while. I finally got it to the 90s, and then I started to feel very weird, and it felt like my heart was doing something funny, and all of a sudden my heart started racing again and went up all the way up to like 165. And I felt like my breathing issues were back, and I got shaky. My left arm was shaky. It finally went down, and I still feel really off. When I get up, my heart rate shoots up, and I have chest pain, and I deal with dizziness while sitting. Is this normal for someone with POTS? My POTS symptoms are a hit and miss, and my heart rate doesn't always shoot up like that. Mine happens like if I'm standing washing dishes, my heart rate will go up to like 135. But what happened today after working out really scared me, and I was curious if this is normal.
That's a great question, and actually that describes a classic POTS patient. It's, the individual has kind of gone through life, done fairly well, have a little bit of heart rate increase when they stand up, which is a normal autonomic response to gravity. When we are standing, blood is leaving the brain needs more flow, and it signals to the heart, giddy up, let's get this blood going, so the heart rate goes up. Now, what happened to this person with the exercising and all that was, it was all well and good. The heart rate was going up with exercise, which is supposed to. And interestingly enough, it didn't shoot up during exercise. A lot of patients who have POTS, they'll find their heart rates go crazy when they start exercising, and they can't go. So that tells me this person was probably well controlled normally. They might have overdone it, not sure what the circumstance was. But after resting, the system has to recalibrate. And sometimes it takes it a little while to figure out, oh, am I supposed to be going slow or fast? And so the heart rate came on down, and then suddenly she's resting, and now they take off. And it's just another miscommunication in the autonomic system. And what it does when it does that fast beat is actually the heart in that situation is not working efficiently because it may be going too fast, causing backup of fluid into the lungs, which in turn sets off sensors that make the person feel as if they're short of breath, chest tightness, and other sensors in the heart sense all this, and they may even send a signal throwing discomfort up in the neck and down the arm. And of course, everybody knows when that happens, you're thinking of heart attack. Well, it's not a heart attack. It's the autonomic signal signaling the wrong way. And it's sending up these signals from what it's sensing as something going on in the heart. And it's of course, as a conscious mind feels the discomfort going down the arm, the neck, and it's like, oh my God, this is horrible. Maybe I'm dying. And that sets off more adrenaline rushes, which in turn worsens the anxiety that this causes. So it's a vicious circle. And the best thing is to remember that if you've been through cardiology, you've been checked thoroughly, you know your heart is strong. So this is your autonomic system that's acting up. It's not the beginning of a heart attack. It is very tricky for patients, and obviously some get scared and go to the emergency room, and they'll be told, oh, you're fine. And that's why they're told they're fine. They are actually fine. It was just a blip on the radar for the autonomic system. So also the other thing about this is that this whole thing will set up this anxiety. So patient goes to cardiologist and they don't explain this well. And that sets up more anxiety about what if they're missing this and what if they're missing that. And unfortunately, it's a vicious circle. So once you know you have POTS and you've been checked, now you can rest assured that your symptoms are simply related to autonomic dysfunction and not from something else. Now, you may need periodic testing just to make sure that that status is correct, especially if you're in the older age group. But when you're younger, it's really not an issue. I'll take the next question, April.
Okay. Dr. S mentioned that I was working off willpower and that it could take one bad period, one case of stomach flu or such to give me a setback. I didn't fully understand that at first. What is the process physically that causes the body to become unbalanced, and why does it take effort, energy, and time to rebound harder than others? I'm assuming our hearts are working harder, but why can we be wiped out so easily like hurricane stress heat? If you don't have IV saline, what is the best way to hydrate and rehabilitate?
Okay, this is another very common issue. And it's, folks with autonomic dysfunction are going along fine and they can push through. Some people actually do push through. I find them highly functional and they don't get it. Why can't I do this? And it just, that high functioning level has its toll on the body. In other words, you're drawing a lot of autonomic power. Autonomic power is simply neurotransmitters. These are chemicals and hormones that are used to signal between the brain, other control centers, to your organ systems back and forth. So normally, you have a steady supply being regenerated and these are being replenished. But when you have a stress on that system, it's actually using a lot more of these neurotransmitters. And I like to call it the autonomic battery because literally it's like there's only so much. And if you had a little indicator light on the patient, you'd see them going from green, orange, red, and then, oh, we're about to power off. And that is why the patient feels awful because the level has gone down to where the multiple things cannot be done. Only vital organs can work, such as the heart and the brain. and it forces that patient to rest and go to the horizontal position, which also happens to be the position in which you recharge these systems. It's very much like when you're laying down, you're not using a lot of metabolic processes that you would be if you were running around the house or maybe even exercising. You actually are giving your internal systems a chance to rebuild the neurotransmitters back into the battery, so you're recharged and off you go. That recharge may take a lot longer than usual. In other words, some patients will be sleeping 6-8 hours, but when they've done something like this, it may take them 14-16 hours or even a couple of days to regenerate what they have used up. When there's hurricane stress, that means there's multiple things going on. Number one is obviously the tension and anxiety of what's going to happen. Are we going to be hit? I need to run to the groceries, get gas up, etc. That's a physical stress. There's a mental stress of anxiety. And then there's barometric stress. That's simply saying that when these storm systems are coming through, the atmospheric pressure is dropping. And so what's happening is the blood vessels normally are being squeezed in to help support the circulation are now in an environment where they can be a little bit more flabby. So when you stand up, blood tends to go towards your legs. And so you need a lot more autonomic energy to force it back up to the brain. And it's kind of, it's interesting right now with all these hurricanes that we're seeing, we are getting so many calls from sufferers with, why am I suddenly decompensating? And that's precisely why. It's not that you did anything different, but it's a dynamic situation where when you see there's a hurricane coming, ideally don't wait till the last minute to prepare. Start doing things in small amounts if you can, so that you break up tasks so you don't exhaust your battery. And it's easier said than done, I understand, but that is why you feel bad. And if family members understand that and they say, okay, yeah, let's chip in and help because she's going to exhaust herself or he's going to exhaust himself, whatever, it really helps, because then there's that guilt from having to lay in bed while everybody else is running around like crazy is alleviated a little bit. So really, it all goes back to very simple things. When there's a stress on the body from an external system or even internal, like if you have an infection, if you have had surgery, these all deplete the autonomic neuroreceptors. So that's why we feel like that. The second part of the question was, if you don't have IV saline, how can we hydrate? So that is done, of course, with water, but the water needs to have electrolytes in it so that when it's drunk, it's not just simply flowing through the bloodstream and out in the urine, because that's what drinking lots of water can do. It just goes in and out, and you can be drinking a gallon and you're like, why do I feel dry? Because your cells may not have retained enough of the moisture from the water. They need electrolytes to balance it out. The electrolytes also maintain blood volume. So water and electrolyte. Electrolytes are things like salt, potassium, magnesium, and a whole host of other things, but primarily salt, sodium chloride. That can come in the form of something oral, like extra table salt. Some folks like using Himalayan salt, whatever. Those are fine, or even salt tablets. Or you can go for a more elegant solution where they actually combine different electrolytes to the right proportions. And there's multiple commercial products. There's one called Vitasium, comes in liquid, capsules, chewables. And then there's the other ones, Liquid IV, MyHigh, Noom, etc. There's a whole host out there. the key is to use what you're able to tolerate, because some patients can't tolerate higher concentrations of electrolytes, so you have to kind of make up your own thing. But just remember, it's a variety. Some people can do well with this water and a little bit of electrolyte, and others need a lot of electrolytes. So sensitivities, even to these natural electrolytes, is variable. But I know the group does a good discussion about how and which ones to use. So they're all okay. It's just a question of what suits that individual. Go on to the next question, April.
Okay. I believe the cause of my dysautonomia is high levels, or it was high levels of radiation therapy to treat my stage 4 squamous cell carcinoma. I suffer from chaos in the hypothalamus pituitary axis, including the adrenal, gonadal, thyroid, somatotropic, and prolactin axis branches. Are there any treatment protocols available that can balance the sympathetic, parasympathetic, and enteric nervous systems?
Okay, so that is an amazing question, and I thought about that for a long time. I'm like, wow, this is a one for the professors. I'll be honest, because I'm looking at this. I don't know of any specific protocols that I could say, yes, let's do this and it'll just work. Usually, my approach in this situation has been to kind of apply all the basic stuff that, the hydration, salts, etc., compression, and then use medications in either progressive amounts or in combinations. Generally, the ones that raise blood pressure and help keep volume in, like midodrine, fludrocortisone, those help with that. There's a newer one called droxidopa or Northera. That helps a lot of people. There's other ones that we use sometimes, like pyridostigmine or mestinon is the trade name, or dicyclomine, Bentyl, which is that trade name. So, and then going on higher up this level, if you go to some of the autonomic centers, they might even consider use of somatotrophin. These are hormone stimulants which help everything settle down. And I think there may be a few individuals who would actually benefit from going to a teaching center where they do a lot of research on these therapies. Our local ones, of course, Vanderbilt, there's the Mayo Clinic, and both in Florida as well as Arizona, but even going up north to the main Mayo Clinic, possibly Johns Hopkins and so on. So they have research centers. It's not the easiest thing to travel when you're dysautonomic. So it's a little tricky, but fortunately, one good thing about the current pandemic is that medical consultations have now been opened up to allow patients to see doctors virtually across the country. So I'm sorry I couldn't give a direct answer, but it's kind of a general answer to a very complex issue. Just one other thing I would like to add on that is that radiation therapy is, especially high dose, can really disturb the autonomic system. So can chemotherapy. Some patients on occasion I've seen who have autonomic dysfunction, which also affects their joints, and they have rheumatoid symptoms, Sjogren's syndrome, psoriasis. They get put on biologics. These are powerful medicines which are generally very useful, but in some individuals, they can also set off the autonomics in the wrong direction. there's the old-fashioned hydroxychloroquine, which is used commonly by the rheumatologists. I've had a few patients who didn't know they were dysautonomic, and they got the normal doses, and that sent them in a tailspin. So it's not that they shouldn't be used, it's just that one has to be careful and look out and try to convince your doctors to go low initially and then work your dose up. I think I'll go on to the next question. I'm wondering there.
Okay. Number 5 is, do you think nutritional deficiencies of patients with dysautonomia are a factor in regards to symptoms? I learned from the micronutrient test that I am deficient in copper, B6, glutathione, thiamine, niacin, manganese, folate, glutamine, inositol, Spectrox, and Immunodex. Any advice?
Yes, well, this is obviously somebody who's been searching hard for a solution, and that's good. All those that were, they were all the items that were mentioned, some were minerals and some were amino acids and micronutrients. Frankly, everything counts. Micronutrients, macronutrients, and they are needed in trace amounts, oftentimes, of micronutrients such as copper, selenium, zinc, things that you might not even know about until you read the fine print on your bottles of vitamins and whatever. But they need it in micro amounts to help cells work correctly. So yes, for some patients, that's a worthwhile journey. These tests are not necessarily easy to have done or obtain because of insurance issues and so on. And frankly, what I tend to do, if somebody asks me about these, I will send them to my naturopathic practitioner colleagues who are more familiar with these, because that's what they actually deal with day in, day out, is looking at how they can help their patients using naturals as opposed to manufactured medications. So they tend to kind of know which test to order, and also they carry the micronutrients which are in a purified form to correct the deficiencies. So this is a, if you want to do it, it's fine. It's just that it's a little trickier than it may look, because you also have to remember that just what I mentioned about sensitivity, it may look on paper that you're deficient, but oftentimes in dysautonomics, I've noticed when we track them over months and decades, those so-called low levels are actually part of the way their cellular and genetic makeup is. So no matter how hard I push to get a certain level, it just doesn't happen. I've seen that occur with things like vitamin D, where we have some individuals who we can give them more than what would be a toxic dose, and yet they don't budge. Or others who are super sensitive and barely can tolerate the lowest dose once a week. So it's kind of interesting. You just gotta be careful. On the matter of labs and interpretation, a lot of dysautonomics I've noticed tend to have white cell counts on the lower end of normal, and sometimes they're below normal. So of course it triggers worry, because the same person is probably having some fevers and temperature regulation issues, and they're wondering, what if I have some malignancy that's causing it? So they go through the hematologist, and usually nothing is wrong. And the standard mantra is to come back in 6 months, we'll check it again. And sure enough, it just stays there. And over the course of time, when you see these patients, they actually don't change. And that is where they tend to run. And their systems, which I believe is coming from the autonomic system, telling the bone marrow, this is how many white cells to produce today, it's kind of stuck at that level. So the regulator is saying, well, that's it, that's enough, you don't need more. And conversely, we have patients, for example, who may have high red cell counts, and we're wondering, is this some kind of problem within the bone marrow or in the hormonal system? But ultimately, nothing is found. And so we don't have to do anything specific with these uh, so-called abnormalities. This is very important because oftentimes we get wrapped up in numbers and don't treat the patient. Sometimes the doctor is wanting to push a drug because a number on a piece of paper, like the thyroid, oh, it looks off or it doesn't look off, and they're regulating everything based on a number. And I think over the years I've learned you've got to do it more by how the body is reacting. The numbers are a guide. So the physician can use it just to make sure we're guiding the patient correctly. But it's a lot of teamwork here. It's not just, oh, do what the doctor says and that's the rule of law. It doesn't work like that in this condition. I said it's discussion and trial and error. So I know some of my patients get frustrated when I don't give them exact numbers because it's like, I don't know. I'll be honest. It's like you might be that one person who doesn't need a lot of medicine, or you might be the person who needs 3 or 5 times the normal dose that we would give. So it's a lot of judgment and interaction between what we see on paper through lab work, what we're seeing on the patient, and using our medical knowledge to help the individual. Let's go ahead with the next one, April.
Okay. Number 6 is, if blood volume is an issue for the majority of dysautonomia folks, why isn't blood volume test or EPO hormone levels not checked on more patients? Since saline IV therapy can't replace red blood cell volume.
That's an awesome point. And actually it's frankly because when the evaluation is going on, it is complex and that tends to get overlooked. Partly, I think, is also in the back of our mind sometimes is when you do diagnose certain things, sometimes it's hard to get insurance companies to let you do the right thing. So, but I think that's a very good point and probably should be something which can be done for more patients. Oftentimes, patients come to the physician who's doing all this and saying, oh, I've had everything checked and I've got reams of blood work. And yes, unfortunately, this one particular test is not done. But when the physician has a forest of data to look through, it can just get missed. So I think it's a good point. And you can always ask the doctor, how about checking my EPO level so we can check for, so it's all, like I said, it's more of a partnership. So the physician is not perfect and reminding them will help. So that's a good point to bring up. Okay. All right, let's go on to the next one.
Okay, number 7. A lot of folks say that POTS, a lot of folks say that they have POTS because that's what their doctor diagnosed them with. But if POTS is diagnosed by just an increase in heart rate when one changes position, what kind of dysautonomia would it be called if you're having multiple symptoms like high and low blood pressure, extreme fatigue, digestive issues, shortness of breath? And would it be more generalized dysautonomia? And how important is it that we get specifically the kind of dysautonomia we have?
Okay, that's a long, big mouthful there. So here we go. So the POTS syndrome is really mostly manifested by an increase in the heart rate. Okay, so that's generally why physicians will say, oh, you have POTS because your heart rate goes up when you stand up. That's what it means, postural autostatic tachycardia syndrome. The medical mumbo jumbo to say that when you stand up, heart rate goes up. Now, oftentimes the patient doesn't realize that at the same time as the heart rate is going up, the blood pressure is actually falling. And that is all part of this syndrome where eventually in some patients you can pass out because there's not enough blood getting up to the brain. It can cause either dizziness, migraines, feeling of shortness of breath, chest tightness, anxiety, mental fog, and just severe fatigue all the time. So although they may call it POTS and not give it a special label, generally, excuse me, generally that is correct. Now, there are few patients who actually have a different kind of POTS, which is called hyperadrenergic. And what that's saying is that when they do the positional change, the system actually generates so much of a sympathetic surge, so there's a lot of adrenaline flowing around, which then sends a blood pressure up when the patient stands up, not down, which is the usual. So that's a small subsection of the POTS syndrome. And if you have that kind of POTS, then the treatment plan does change. So once it's recognized, there are some modifications to the overall way we use medications to control those symptoms. Unfortunately, a lot of those patients who have the high blood pressure when they get up and also have problems with the pressure dropping too low at times. So it is a very delicate, almost acrobatic balancing act between maintaining blood pressure that is enough for the brain to function and blood pressure that's not so high that we create a possibility of stroke or some other event. And this is the reason in my practice, I'll often use what I call a blood pressure clamp, where we're using some therapies, treatments, medicines, what have you, to bring the blood pressure up. And then I'm using a second set to keep the top number from going too high. It definitely becomes a juggling act there. So the other thing is that the dysautonomia syndrome is a vast umbrella that covers a lot of different conditions that are connected in. POTS just happens to be one of the major ones, but there's also something called orthostatic intolerance, meaning when you stand up, you cannot stand too long, you need to sit down. And the rest of you may be fine, but that's your only symptom. There can be other conditions such as inappropriate tachycardia syndrome, meaning the heart rate's fast, and you could be sitting down doing nothing, and this is going too fast. Some patients, unfortunately, will have their heart rates going over even the 100 beats per minute mark for more than 20–30% of the time, which they may not feel bad. Some people do, some don't. But the physician will be concerned, because if you allow the heart rate to remain in those high ranges for decades at a time, there is a potential for weakening the muscle to cause what is called a tachycardia-mediated cardiomyopathy. It just simply means that the muscle gave up and said, okay, I can't keep going this fast. And luckily, if it's recognized, it is treatable, so it's not the end of the world. But this is why your physician might want you to be on medication when you say, I feel fine. Well, we're looking at those rates and that they're excessive. Other things that come under the dysautonomia umbrella would include things like mitral valve prolapse, Ehlers Danlos syndrome, which is EDS, hypermobility joint syndrome, all the rheumatoid conditions, rheumatoid arthritis, Sjogren's syndrome, dry mouth, dry eye syndrome, chronic fatigue syndrome, irritable bowel syndrome. And then there's a special one, mast cell activation disorder. That's where it's one of the automatic systems where the mast cells in the body are not regulated correctly, and they overreact to allergens or stimuli. And they've released a lot of histamine, and next thing you know, the patient is having either swelling inside their stomach, on the skin like hives, and it's a difficult disorder to treat, but we usually have the immunologist and allergist help us with that. And finally, there's also one important thing that often gets missed in dysautonomia patients is it's what I call post-traumatic stress disorder. It's like they've usually been battered by all the conditions that they've experienced with lack of answers, and it creates an incredible amount of stress on the autonomic system to get over that. Luckily, once they're diagnosed, it's better, gets slowly better. Another kind of post-traumatic stress which can cause dysautonomia is things can be something like childhood abuse. It can be a motor vehicle accident, a surgery, a pregnancy. In other words, life itself can do it, but it all depends. It's a vast umbrella, and we try to put in all these little things in between. I also forgot to mention fibromyalgia, which is really part of this whole thing with the muscles and the nerves misbehaving because the autonomic signals are not perceived correctly. There's depression, anxiety, which can be caused by all this. The anxiety is actually caused by the condition because it generates tremendous anxiety, sleep disorders. So it is definitely a complex disorder which affects any and every system in the body. So a lot of times the patients actually have gone through multiple specialists and being diagnosed with X, Y, Z, but really it's all, when you tie it in, it's all back to dysautonomia. I know that's a kind of a little bit of a long answer, but I hope it helps. The next questions, go ahead with this, April. I see we're running low on time, so.
Well, actually, it's almost 10 minutes till, so we'd like to stop these questions for right now. If we can come back to them if we have any more time. But we'd like to see if there's anybody online in the audience here that would like to ask a question to Dr. Patel. If you will raise your hand, we'll see you and I can unmute you, or you can unmute yourself. Okay, I see Jessica. Hey, Jessica. Can you unmute your phone?
Hi. My question regards the spine. Should we be feeling a lot of pain in our spine? Typically when we may run a fever, like it could be an indication of getting sick.
Okay, that's a good question, Jessica. It's very interesting that patients with dysautonomia, EDS, whatever, they have kind of hypersensitivity. They feel things which most other people may not, and therefore they're looked upon as, that's weird, I've never heard of it. Well, guess what? What you just said makes all the sense, because the spine has spinal nerves which need nourishment, and just like the brain, they're dependent on the flow of blood from the heart to your head and to your spine. And they're very sensitive, just like your brain. So some patients who have fever or something coming on, they get headache or a light dull ache. Others will actually get discomfort in their spine, and yet others will feel it in their joints. So and it is not unusual for patients to describe that. And it just says that, oh, you're about to probably get sick, so you need to increase hydration, rest, electrolytes. And probably, depending on the individual, might want to throw in a little more vitamin C and so on. So that is kind of important. The other thing also about the neck is that that's where all the autonomic outputs and inputs from the body go through, up and down to the brain. So any kind of disturbance in the neck area worsens autonomic dysfunction, which is why a lot of folks who have motor vehicle accidents with whiplash or back injuries, whatever, they have a great deal of trouble restabilizing their condition. And they go for years and seeing, physical therapists, orthopedists, what have you. And unfortunately, it's actually the reason they're having problems is that the autonomic system was hit badly by that shock of the condition that damaged the, or at least disrupted outflows from the brain to the rest of the body.
That makes sense. I had whiplash recently and went through a bad flare afterwards.
Yeah.
That makes sense.
Okay, great. Is there anybody else that has a question? Raise your hand.
Tay has her hand raised.
Who?
Tay.
Oh, okay. Tay, go ahead and ask your question. Go ahead and unmute your mic.
Okay. I believe I'm probably headed towards some shoulder surgery, and I'm wondering if most anesthesiologists understand dysautonomia and what preoperative, interoperative, and postoperative management will be used for my surgery. Do they understand? For instance, I have a little bit of trouble breathing when I am supine. I recline slowly to avoid tachycardia. When I go to bed, I am careful and recline slowly. And I wondered, how much do the anesthesiologists understand about this?
Yeah, that's a great question, Tay. And in fact, I always ask our patients to be sure to have whoever wants to operate on them to be contacting us so we can give them the specific recommendations for their condition. Generally speaking, what I will tell the physicians is that, number one, this patient is very sensitive to medications, so please use small amounts frequently rather than the usual big slug at the beginning of the procedure, which then once it's in, they cannot adjust. So I always tell them, you got to go slow, and you can always give more if needed. The other thing I would also tell them is that, like pain, pain tolerance is very variable in dysautonomic. Some patients, they just look at the tiny bit of pain medicine and they feel fine, and others need about 10 times the normal dose. I have some dysautonomics who may be able to take 100 milligrams of morphine, where 1 milligram normally would knock another person out, and they're still talking to me. This is related to something called pharmacogenetics. That's the way your cells are genetically programmed to process drugs. Unfortunately, this is a great technology and medical advance which the insurance companies refuse to pay for reasons that totally befuddle me, because it would save them a lot of money if they actually did it. But anyway, so back to the anesthesia folks. So they're told also to pre-hydrate the patient. So normally they've had you fasting for your procedure and you're dehydrated. And what I would recommend to them is please pre-hydrate, give IV fluids before, during, and after. And I also like to tell them a little bit about, you need to do the surgery early in the morning or procedure so that there's plenty of time for a washout of the drugs they use. Or else, if they'll be waiting till the cows come home until the patient wakes up, because oftentimes the blood pressure will drop and it's so low that then they are faced with, well, we have to admit the patient instead of letting them go home. So I always ask them to try and start earlier in the day so you don't end up with this situation, which is a routine outpatient, whatever it is, and the patient gets stuck having to pay an extra night's care. Some patients actually need that extra night. So I actually ask them, this particular patient will do better if you just plan on keeping them overnight. In terms of care afterwards, it's a bit of a random thing, because unfortunately, the medical profession and nurses don't always understand autonomic dysfunction. And the way systems are set up is it's a cookie cutter approach nowadays where everybody gets the same treatment. Well, this is how the protocol is, so you follow the protocol. But usually a good letter from the doctor explaining what needs to be done helps in when the patient advocates for themselves and says, you know, I have this condition, da 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 da. Okay, yeah, oh yeah, doctor said so too. So they do tend to respect what needs to be done better when you have the reinforcement from the physician. In terms of aftercare with surgery and so on, physical therapy especially, you know, because there's a crossover between autonomic dysfunction and EDS, you got to remember that the tissues may not heal as quickly and as fast, and may even be weaker than in a normal patient. So physical therapy has to be careful and not to be so exertional that or so forced that it actually tears up the tissues. That's a mistake because, again, the physical therapists, the good souls they are trained to do certain things and push like crazy. And you need to find one that's more understanding and says, oh, you might have lax tissues and you may have these conditions. So we don't want to push you the usual 20 reps. Let's just do 5 and call it a day, or split it up over the day. So to answer your question, Tay, it's really kind of difficult to educate everybody, but at least in this parish, St. Tammany Parish, physicians are becoming more aware, and they see my recommendations and they're much more likely to follow them because they've seen when they do that, the patient does well, the recovery is good, and that everybody can go home on a timely fashion. Thank you.
Awesome.
Okay, one other quick question here. May I?
Sure.
Okay, with a surgery of this type, would a ultrasound guided interscalene bronchial plexus block help keep from having issues with the dysfunction? And who would ask for that, or how do I be sure that that is in the plan for me with my surgery, having dysautonomia?
That I think is kind of a discussion that would have to go with the anesthesiologist who's actually doing the blocks, because they need to be comfortable with that particular block. And what a block does, just for the rest of the audience, is instead of submitting the entire body to drugs by giving general anesthetic, you are localizing things to the area that's being worked on. In other words, if it's the shoulder, the block Tay is talking about helps with taking away the pain, so the surgeon can work on the shoulder without having to put the patient completely to sleep. They usually will give a little sedative just to make things a little easier, but it won't be like you're fully out. So definitely if both the surgeon and the anesthesiologist are comfortable with giving you what we call conscious sedation together with a block, that would make sense to do that. Some surgeries are so complex and difficult that it would probably be not a good idea because they may not be able to achieve the amount of pain control, which in turn would actually be sending signals back up the entire body, and they may end up having to put the patient under anesthesia anyway. So it's a judgment call for those physicians and the patient.
But you know that we so very often in our family situations meet our anesthesiologist before the surgery. They come in and shake your hand and say, hi, I'm the anesthesiology doctor, whatever. And, you know, should I maybe ask, beforehand or make an interview with the anesthesiologist?
Yes, that is actually the way to go about it.
I don't know who may.
That's the way you need to go about it because, again, it's a question of advocacy, self-advocacy. They may consider it a pain in the neck because they're busy and who wants to do that? But frankly, if you do it that way, they'll remember you and they'll say, okay, this is the lady, we need to be careful and this is what she wants, instead of some random guy on call showing up. And usually if it's elective, they may have their schedules made so they know who's going to be there. If it's an emergency, it's an emergency, but it's well worth asking to talk to anesthesia ahead of time. And that way you have a better chance of getting what you want to do.
Now,
Okay.
I will be
Awesome.
getting.
I'm sorry, in the interest of time, I need to go ahead and see, is there anybody else that has a question to ask Dr. Patel? Let's see,
I don't have
Stephanie, is that you?
Connection.
Go ahead, Stephanie.
So since pregnancy can be a trigger for dysautonomia possibly, how safe is pregnancy for somebody who has dysautonomia, and are there specific problems that the pregnancy can cause to exacerbate dysautonomia permanently?
Yeah, well, Stephanie, that's a good question, but it's a little tricky because it's not that pregnancy always causes it. It can be associated with it in susceptible individuals. And by susceptible, I'm talking about ladies who might have been having issues before, but they were just blasting through. They were dizzy and having fatigue. And then they became pregnant and they didn't realize you got to slow down. You're not the normal pregnancy. You actually need a lot more support and help, and don't feel bad about it. And so long as the family gets it and they're supportive, it works. The problem is where there's not the support systems or whatever, and the person is trying to work, they're trying to be, take care of the pregnancy, then the baby. It's just overwhelming. So it's not that it's a contraindication to become pregnant. It's just that once you're aware, it's like, okay, this is what I need to do. Next time around when I have a baby, I'm going to make plans where it's not so crazy on my system. And frankly, it's amazing. We have one patient who just, floored us all because of the odds. Having had severe dysautonomia, being unable to drive because of passing out, and ended up having treatment and ended up with multiple birth. And, it was amazing that just through both willpower and also a lot of guidance, she was able to carry it all through and is doing well. So it's a little bit of encouragement from the treating physicians, as well as understanding the condition and knowing what the limitations are. And nothing can be perfect. Unfortunately, this is the issue in pregnancies. No mother wants to harm her child, but it's like you have to kind of work with both mother and child. So it's a close partnership between the dysautonomia specialist and the high-risk OB or whoever they're seeing, the regular OB, so that everybody understands, yes, there's flexibility, let's try this, let's try that. And generally, I've found the OBs are very grateful for somebody to help them along with their patient. So it's not really that a lady may not ever have kids again. I always say, look, there's always, your systems do heal. So, don't let that put you back.
Okay, I think Janae, do you have a question? Okay, go ahead and unmute your microphone.
Thanks. Hi, Dr. Patel. Just a quick question. In terms of this presumed second wave of COVID, should we be overly concerned or take any additional preventive measures?
All right, that's a great question too, Janae. Thank you. Initially, we were all fearful that our dysautonomic patients would be, really having major problems. However, as time has gone, I'm seeing that this really for dysautonomia patients, unless they actually have an immunocompromised situation, they're needing, for example, IVIG to boost up the immune systems, the majority need to just follow the guidelines, masking up if you're in public, hand washing, and avoiding large crowds. Even the few who might have had the COVID have done well. And of course, it's not, the recovery is terrible because, for the ones who are affected badly, it's hard. It is hard on normal patients who don't have dysautonomia, because COVID can actually affect the autonomic function as well. So I think there's going to be quite an epidemic of patients with autonomic dysfunction if they were normal before and they got COVID. Additional precautions would be like just hydration. Don't let yourself get overtired. Maybe consider, these are unproven by the way, but I usually suggest them anyway. Vitamin C, maybe 500 milligrams a day, maybe a little zinc, 30 milligrams a day, and vitamin D for sure. You make sure your levels are good and up. I usually recommend double of what the lab says is normal, because I've found over the years that patients who run in the higher ranges do much better. They have good recoveries from infections as well as their autonomic crashes. So that's a quick answer to your question.
Okay, and then did the lady from Downsville have a question?
Yes.
And what is your name?
Carol.
Carol, okay. Go ahead.
I've passed out 6 times since November of last year and tried to find help in this area, North Louisiana, and nobody knows about this condition. I'm coming to see you. I did get a referral. And what tests would you like to have from me for me to bring to you?
Well, thank you, Carol, and thank you for making the effort to come on down. Normally, what I like to see is whatever they've done in terms of like blood work, echo, which is a sonogram of the heart, monitor, if they did a stress test or a tilt table test. So all that information is good. And usually I ask the patients either to, actually to contact the office so that they can facilitate getting those records so I can review them ahead of time if possible. It makes the whole visit go much better. And then we can kind of see what we need to do to help you. And yeah, it's very unfortunate that there's not more physicians who can help up in your neck of the woods. But, again, like I said, it's amazing what we've been able to do with telemedicine and how we can stabilize patients once because a lot of all this, interestingly enough, is explaining what's going on so the patient knows how to control their condition. So I'm looking forward to helping you with that.
Thank you.
You're welcome.
Okay, awesome. Can we take one more question? Does anybody have one more question? If so, raise your hand.
Yeah.
Stephanie, are you trying to talk? Your microphone's not on.
Sorry, I thought I unmuted it. Cindy and Crystal both put up a hand, even though their screens are off.
Oh, okay. Crystal?
Hi. Hi.
Hi.
Hi. Okay. My question is, and I'm sorry if I'm repeating something. I was late here. I was still with my kids. That has already been addressed. I don't fully know what's going on with, in terms of diagnosis yet. I just know this has been going on since the 4th grade. But I've had and when I say this, what I mean is, you know, when I stand up, I get my heart rate accelerates, get weak, I get shaky. I feel like I'm about to pass out, but I've never actually passed out. I've had times where it was really, really bad for a year or two, and then it's like not even an issue for multiple years. And currently, I haven't had like a really, really bad batch in quite some time, but like it's just, it still affects me. I get a little weak, a little shaky, but not to the point of I feel like I'm going to pass out anymore. Is that a common way that I don't even know how to say the word, dysautonomia, you know, is that common for it to present that way, where there are periods where it's really bad and then it's like it goes into remission a while and it comes back, or is it usually pretty steady throughout lifetime?
All right. Well, thank you for that, Crystal. Yes, the actually what you're describing is very typical. You have your condition is dysautonomia, and you, from the sound of it, you have POTS, which is where when you are standing and your heart rate goes crazy, you may get dizzy, weak, whatever. And it will come and go based on a lot of different factors. And especially because you've had it since you were young, it can be controlled. And this is what I was talking about earlier about education. Once you know what you have to do, then you know, oh, wait a minute, this is I'm going downhill. I need to make arrangements where I can rest more, I can hydrate more, and so on. It's very tricky if you're a mother with children and family, if everybody is not on board. And that's, right. I find that's the biggest problem often is the patient gets it, but the support systems are just not there.
Right.
And it's very sad because this affects the whole family. And if the rest of the family members are not really interested in helping, it's sad. So what I usually suggest is, I don't know if they forward this to you, but I have a little sheet with all kind of links on it. And one of them is a link to a Fox 8 special I'd done some time back. And sometimes you get the family to sit there and they watch it together and they like, oh, wow, that lady looks normal and she's out there hunting hogs and now look at her. And
right.
Yes, in other words, you look normal, but you're suffering. And they sometimes the light bulb goes off and they're like, oh, and actually a man in a white coat actually said so, that she's not nuts, that she's not lazy. That helps it. That's what April was talking about earlier, the validation, that suddenly a MD has told you a diagnosis, which is actually, is not some doctors think it's like, no, it's not a diagnosis. It's actually in our book of codes.
Right.
You don't get a code on a diagnosis that's nonsense, okay? So they need more education, unfortunately, but yeah, you have a diagnostic code. Right. There's a treatment that's, it's a lot of treatment plan, simple stuff and more complex.
Right.
So the key is to know that yes, you're not nuts, and B, there's help.
Right. And
that your condition will go up and down based on many things, such as the storm systems coming through. But don't lose hope.
Oh, thank you. Thank you.
Welcome.
Okay. There was one other person besides.
Hey, I'm here. Can you hear me?
Yes.
Okay, I'm sorry. So Dr. Patel, you actually recently started treating my 18-year-old son for dysautonomia. And I've actually had some health issues for about 19 months now that have been pretty perplexing to mainly neurology issues that I've had. And I've kind of left the neurologist pretty perplexed. I did get a diagnosis of hydrocephalus back in November. However, the neurosurgeon questioned whether that was an accurate diagnosis. So, and just learning more about my son's condition, reading the book and just, participating in these things. My question for you is, could there be a connection at all between dysautonomia and hydrocephalus?
Okay, so that's a very good question because we get a lot of patients who've been through because they had various neurologic-like symptoms and they get umpteen MRIs, CAT scans, 5 neurologists. They all argue. One says, yes, you have hydrocephalus. Other one says, no. And it's mass confusion by the time they get to me. And I'm like, okay, frankly, I think it's overdiagnosed, hydrocephalus. I mean, it has to be, there's a syndrome called the Budd-Chiari syndrome where the brain actually tries to sink through the hole that is all the connections are going through. And that is not good, So, but generally speaking, we see a lot of patients who have neurological issues and they go to the neurologist, and then finally when we actually fix what's really going on, which is changes in the flow of blood to the brain, things settle down. The anomaly that they're seeing on their CAT scan or MRI is maybe just one of those variants that I was talking about earlier. So yes, and the reason I'm just thinking about this is that often I've seen this condition will run through the family. It's partially genetic in that you can almost guarantee when you start talking, the person in the room, if mom or dad, somebody says, oh, wait a minute, my mother had something like this, kept passing out or had headaches and so on. So I wouldn't want to discount the neurologist, but I think you should consider the evaluation for dysautonomia because that would actually let you know if that's part of it or not.
Okay, great. Thank you so much.
You're welcome.
Kim, you got a question? Unmute your mic.
I do have a question. I had sent it in online, but what I wanted to know was that, I've only been diagnosed for like a year and a half, and I'm getting IVIG every other week. And I'm just wanting to know because how do you know how to manage like what you can get up to do? Because some days I'll feel okay. And if I try to do like a couple of activities around the house, by the end of the day, I'm like in so much pain and in the bed. Like, how do I judge what I can and can't do without overdoing it? Wow,
that is that's a tough question because you see everybody's different, and I don't like to restrict people unnecessarily. If I said to just go ahead and don't do anything, that makes no sense, right? So actually, you have to learn, Kim. You have to learn. Okay, you know what? Today's a good day, so this is where I'm not going to use all my energy up. And for those who haven't looked at it already, go and Google the spoon theory. It's awesome. It explains what I'm saying very simply. You have so much energy and you have to use it up as the day goes on. And you're having a great day and you probably think you have 24 spoons and not the 12 that you really have. So you overextend, and then next thing you know, you're like, oh my God, I'm done. So be careful with those days where you have bountiful energy. It's just that, yeah, your battery is now charged, but don't use it up for everything that day. You're better off saying, you know what, I'm going to break up my chores, what I need to do over the next couple of days. And you'll find that you may not have so many low points because guess what? After you did everything and blasted through it, you depleted the system, and you also made it very hard to heal. It's like, you have these, your regular batteries, for example, we recharge them, eventually they're like, oh my God, they barely take a charge. It's a kind of a similar thing where you have to rest your battery, so to speak, on a fairly regular basis so you don't blast through things. And if you know that you've got a big event coming, plan ahead. Okay, you got to get your groceries one day, you got to get the car done, whatever. But it's very tough to tell you how to plan it because it's really an individual process. And maybe make a diary and say, oh yeah, I see what it is. And for some patients, it's actually related to their cycles. And then when they're having them, they're like either washed out, so they know, do not bother setting up anything on those days when they're having their cycle. Others is mid-cycle. It's it's worth doing a self-assessment, make a diary, and then work it out from there.
Okay, thank you.
You're welcome.
Okay.
You got it, right?
Go ahead.
No, I just wanted to say it's about 22 minutes after 1, and I know all of us have very busy lives after this and things to go and do. And I just wanted to make a couple of closing statements. And first, from Dysautonomia, Louisiana, and all of its members, Dr. Patel, we cannot thank you enough for the educational awareness and the support. We just wouldn't be who we are without your guidance. And the second thing I'd like to say is the link for the Fox video, the Fox 8 video that Dr. Patel was talking about, as well as the spoon theory. I will post those on the Dysautonomia Louisiana site, on the Facebook site after this, so you can go back and look at those that we spoke of. The other thing I'd like to make a very important statement to say, please do not go changing any sort of medication or routine that you and your current doctor has based on what you heard today. Today is an education. You take what you've heard back to your doctor, you speak to them about it, or make a phone call and make an appointment with Dr. Patel. But we're not telling you guys to go out and change your medications or go do anything specific that would be drastic to harm you in any way. We do want you to just take this as a knowledge and do one of two things. Go talk to your doctor about it, or call Dr. Patel and he'll help you work through this. I personally wish you all the best. I'm always a phone call, text message, email, or comment away for Dysautonomia Louisiana if you have any questions. And I'm going to let April and then Dr. Patel make some closing statements. And from the bottom of my heart, thank you so very much for joining us here today. April?
Okay. You just pretty much said all that I wanted to say, except just to remind y'all, we will be back right here under the same link again at 3 o'clock. And our support group, we basically go around the room and everyone gets a chance, if they would like to say, hi, I'm so-and-so, and these are my issues. And sometimes it gets pretty emotional and sometimes it's funny, but we learn a lot from each other. We develop relationships, and those relationships become our support system. And then more people, it's like a domino. We help more people. So I just wanted to invite you all and encourage you all to come back at 3 o'clock.
Thank you, April.
All right. Thank you. Thank you both. Thank you, April and Carmen, for inviting me to your event. I do appreciate the opportunity to educate and help people. And as Carmen had said, please don't change your treatment plan based on these generalities I was offering up. You always need input from your physician. And if you decide to come see us, that's fine too. But meanwhile, I just want you all to be well hydrated, well rested, and know that you're not alone. There's at least 4 million people in the United States like you, and probably more, and around the world. So this is coming along, and I really am encouraging my patients who see us to join these groups to raise awareness so they can spread the word and help others. And I do appreciate you all sharing your personal stories with me, because it's a learning process, and I've learned from my patients and their trials and tribulations. And between what they've said, my learning and my experience, I've been able to help people feel better. That's my goal, is let you live better lives. And thank you again, and take care, and God bless.
Thank you so much.
Thanks, Dr. Patel.
Bye.
Bye-bye.
Bye.
Bye-bye. If anybody wants to stay just for a couple more minutes just to chit-chat, y'all are welcome to hang out just for a couple of minutes. In about 5 minutes, I'll turn this off.